So the next thing we need to discuss is the different routes of administration. We're going to start with intravascular. Intravascular, of course, is IV. And this particular route of administration has 100% absorption. And there's no absorption phase. And then it is characterized by no drug loss on administration, and that'll make more sense when we review the oral administration. And the bioavailability, which we'll define later, is 100%. And so essentially the concept here is that you're injecting the drug directly into the bloodstream, and the maximal amount of drug is immediately available to have some type of biologic or physiologic effect. And so here's kind of the clinical correlate. Why do patients in the ER receive drugs via IV? And it's really because of this curve. Here's the plasma concentration over time curve. And you see the maximal concentration is reached shortly after administration. Other things to consider about IV administration is that, it could be an infusion or an IV drip. And so essentially what we're looking at is the ability to control the rate of the delivery of this drug over time. And so there's, this one could be a slow drip over the course of several hours. And in contrast, it also could be a bolus. And so here would be a large amount of drug that's administered via IV. And it would be given in maybe less than 5 minutes. It's the fastest and most efficient way of getting the highest concentration of drug into the circulation. And so, of course, the drug circulates the entire body in about 2 minutes, depending on blood flow and so forth. And transient high levels of the drug are reached relatively quickly. So this is great in an emergency type situation where you need the drug to be rapidly administered and immediately available. However, the downside is that you can't recover the drug, meaning that if you give too much, the patient's going to experience the side effect or the toxicity relatively quickly. And if you gave the wrong drug, of course, you can't retrieve it without doing something like dialysis. And so going back to our patient here and our clinical correlate, the reason that patients in the ER receive drugs via IV is that the time to that peak plasma concentration, so the time from essentially 0 to the maximal plasma concentration, is very short, meaning that the drugs can work very fast if they're given IV. So this is in contrast to an extravascular administration. And so extravascular really means anything outside the vessel, so anything not IV. And so that could be oral. It could also be intramuscular, subcutaneous, intradermal, transdermal, inhaled, rectal, and so on. This particular route actually requires absorption, and you can see it here on the plasma concentration over time curve. If this is the time at which the drug is administered, there's a lag phase in terms of where the drug has its clinical effect. And so that clinical effect can be, within this area right here. But, say the clinical effect needs to occur at the maximal plasma concentration, the time to peak plasma concentration is delayed. And so if you need to get to this part of this curve, you're essentially waiting this whole time for this drug to work. And in some cases, that's fine if they're on a standard drug that they take for a disease that's being well managed. In an emergency type situation, you really wouldn't want to wait this long, especially for a drug that could be life-saving. But for stable patients at home on oral medication, this is just fine. They can take their medication at 8 a.m. and they can experience the therapeutic effects of the medication, say 9:30, 10 o'clock, 11 o'clock, and so on. But this particular phase, this particular route of administration is evidenced by the phases of the LADME system. And so there is a liberation phase, which is here. And this particular phase is the absorption phase. And so this process of oral administration is going to require absorption. And the patients may experience some drug loss. And we'll talk about that mechanism briefly coming up. But essentially that, if you deliver 40 milligrams of a drug via oral capsule, most likely there will not be 40 milligrams circulating over here. Some of that drug weight has been lost to metabolism, excretion, protein binding, and so forth. And so the concept is that the bioavailability is going to be really important. So 40 milligrams is not going to be biologically available. It'll most likely be somewhere between 25 and 30, 35 milligrams available. And so you know that you're going to have some percentage of drug loss. Okay, and so within oral absorption or oral administration, really the first kind of absorption-based surface is the buccal mucosa, and this is great. So this is an area of rich blood vessels right under the tongue, and in fact, this is how nitroglycerin is administered. You put the quick dissolving capsule or tablet underneath the tongue, and it gets absorbed really quickly. The patient doesn't actually swallow the nitroglycerin. It gets absorbed under this buccal mucosa surface. The next major site of absorption is the stomach, of course, and the absorption time is going to vary depending on the amount of food, the amount of fat, the content of the stomach, whether it's an empty stomach or a full stomach, of course, the viscosity and so forth. And the pH of the stomach can range from anywhere from 1 to 2, and we talked about the importance of having kind of an acidic environment, keeping those drugs in their slightly inactive state. And it's been shown that the gastric mucosa absorbs drugs best with a pKa between 3 and 3.5. And those are mostly weak acids. They're also water and lipid-soluble type non-electrolytes, and they get readily absorbed by passive diffusion. The majority of drugs that are out there, with some exceptions, of course, follow this particular criteria. The next route of administration the next phase during oral administration that the drug could encounter, the next phase of oral administration that the drug can encounter is, of course, the small intestines. And it's really the primary surface for a lot of the orally administered drugs. And of course, the rate is also dependent upon a few physiologic factors that can change from day to day. And the absorption here can take anywhere from 30 minutes to up to 2 hours in patients that have kind of a slow GI process. And the pH is a little bit higher. Here it's about 6.5 or so. And so drugs with a pKa right around 6 are often best absorbed within the small intestine. And of course, changing the motility of the GI system in terms of residence time is, of course, going to affect absorption. And of course, going back to fundamental biology, the intestines have these villi, which increases the surface area. So a larger surface area means for a more efficient, faster absorption phase or process. The next thing that we need to discuss is what's called the first pass effect. And so essentially, if you look at the circulation of blood through the GI system, blood from the GI tract goes to the liver via the portal circulation and then reaches the systemic circulations. Lots of drugs are metabolized or biotransformed by hepatic enzymes. And so some of that metabolism occurs in the gut wall and some of it occurs in membrane surfaces. The drugs that are taken orally may be partially or entirely metabolized by the liver before they ever reach the systemic circulation. Okay, and so this process or this principle is called the first pass effect. And in some cases, the first pass effect is beneficial, and in some cases, the first pass effect is detrimental, depending on the chemistry of the drug and the anatomic site of where you're intending that drug to have its physiologic effect. I'll give you an example. The statins, which are a group of drugs that are known to dramatically lower cholesterol levels, have a huge first pass effect, which is great because they are biologically activated in the liver, and the anatomic target is the liver because that's the site of, primarily the majority of the cholesterol biosynthesis. So you get a huge deposition of biologically active drug at the site where the cholesterol synthesis is occurring. So in this case, it would be a really good approach to therapeutic management. And of course, there's other absorption surfaces that you should be aware of.